This is the coronal CT of a patient demonstrating sinusitis on both sides, though more on the right side, with evidence of maxillary and ethmoidal sinusitis with nasal polyps. Here you can also see frontal sinusitis with obliteration and opacification of the interfrontal sinus septum cell with a polypoid lesion approximately coming out of the same. The parasagittal cuts are crucial in defining the anatomy of the frontal recess, the frontal sinus, and the trajectory of skull base before planning the sinus surgery. We see here the location of the frontal sinuses, the interfrontal sinus septum, and the small interfrontal septal sinus cell located just above the nasal septum anteriorly. We see here how the same looks on a parasagittal section, and these sections are very important in overall orienting ourselves towards making a perspective of three-dimensional anatomy of the paranasal sinuses with regards to endoscopic sinus surgery. This picture shows us the polypoidal lesions on both sides of the nasal cavity. You begin from the right side with an uncinectomy. This is a standard procedure. We use the standard backbiter for doing the uncinectomy. This is a much safer way than using a sickle knife, which has the potential to penetrate the orbit. As we create 1 or 2 incisions down to the hard wall of the maxillary, terminate and maxillary wall, we do not have to go much more anterior because that can disturb the nasolacrimal duct. And once we have given a broad, sharp cut flush with the lateral nasal wall, we can use either a ball probe or, in this situation like so, a frontal sinus turret, which helps us invert and outfracture the uncinect process, also popularized by Professor Peter Warnold as the swing door uncinectomy. Once completed, we can use the same instrument or a curved suction to enlarge the enterostomy downwards. Before that, it may sometimes also be prudent to remove some bit of the polyps that fill the choana and the nasal cavity to overall get some space in the posterior nasal cavity for observing the choana. The choana happens to be a very important landmark in sinus surgery, whether it is primary or revision, and helps orient the surgeon even in a bloody field as to where the approximate location of sinuses is. Before proceeding into further sinuses, it is important to remove the redundant mucosa and some bit of anteriorly placed polyps before we can make sense of where the approximate location of the ethmoids and the maxillary sinuses is. Before we progress to the ethmoids, we strongly recommend that the maxillary sinus be widely opened, and a good generous wide enterostomy in polypoidal disease not only helps the surgeon keep perspective of the trajectory of the sinus surgery, but also helps in preserving landmarks. How so, we will shortly discuss. As we see here, we are still debriding and debulking some of the polyps that fill the middle meatus to overall gain a space inside the middle meatus. We can start seeing the tail of middle turbinate already medially and the maxillary antrum laterally. The small polyp seems to be coming from superior, and the way it is coming medially, it appears so to be coming from the interfrontal sinus septal cell, which was first seen in the CT scan. A straight biting true-cut instrument or a true-cut forceps could be used to enlarge the enterostomy posteriorly, because anteriorly often there is not much space. However, a word of caution, this must not be taken too far backwards flush with the posterior wall, because that risks injuring the sphenopalatine artery and causing unnecessary bleeding. Now, as we see here, we can use the straight tube biting forceps to increase the enterostomy posteriorly, and then using curved suction just to clear the contents of the maxillary sinus. There could be fungus, in some cases polypoidal tissue. Now we are using a navigator probe to point towards the most important landmarks, this being the vertical enterostomy ridge, which is the vertical bone of the enterostomy. This is the transitional enterostomy ridge as it starts to curve upwards, and this vertical enterostomy ridge leads to the transitional enterostomy ridge, and the transitional enterostomy ridge superiorly leads to the horizontal enterostomy ridge, which is also known as the mesoorbital floor. These are important landmarks defining our trajectory into sphenoid and the ethmoids. Now we begin removing the bulla ethmoidalis, again using a back fracture or a swing door technique, where we use our frontal sinus fluid or a ball probe to fracture the ethmoid bulla anteriorly. Now this is again a safe procedure because the force and the force is applied backwards. Thus, even in case the force is more than usual or there is a jerk, very little possibility of injuring the skull base, unlike exerting force backwards. Now this navigator probe points to the horizontal antrostomy ridge, which is the medial orbital floor, the superior wall of maxillary sinus. And that is a very, very reliable and consistent landmarks towards entry into sphenoid sinus or the sphenoid os. The sphenoid os, if not found or scarred, can always be found in the same level as is the medial orbital floor or the so-called horizontal antrostomy ridge. The transitional antrostomy ridge, however, guides our way into the posterior ethmoids, which is the antrostomy ridge between the horizontal and the vertical ones. And following the transitional antrostomy ridge, slightly medial to it, slightly medial and slightly superior, we fracture the basal lamella to enter the posterior ethmoidal cavity. As we see here, we are again using the navigator probe in the same level as the horizontal antrostomy ridge to locate the approximate entry into the sphenoid sinus. And this is the posterior ethmoidal skull base as pointed here. All these partitions in the party walls will need to be removed because that is very fundamental to any sinus surgery, and not removing the entire ethmoidal septations, leaving behind septations in the anterior posterior ethmoids is often a cause for surgical failure or disease recurrence. This is often an understated cause of failure. Now as we go medially towards locating the sphenoid sinus. As you see there, we have just entered the sphenoid sinus, which is normally located medial to the middle turbinate inside the sphenoethmoidal recess. And as you see here, one can again orient as to how the entry into the sphenoid sinus or the sphenoid os lies literally at the same level as the horizontal antrostomy ridge. Now, once the sphenoid os has been opened, it can be enlarged inferiorly and inferolaterally using a straight Hajduk-Coffer bone punch. Just one has to be a little cautious here not to lower it too down without elevating the mucosal flap, because that can injure the septal artery, branch or stenopalatine, and again lead to unnecessary bleeding and wastage of time. Once we have entered the sphenoid sinus, our navigator probe now points to the sella turcica, in the sellar bunch, seen in front of us very clearly. Now again, it's very important to retain perspective, as the sphenoid is the lowest of all sinuses and how it corresponds to the medial orbital floor of the horizontal antrostomy ridge. And once it is located, it can be appropriately widened depending on the pathology. Since we do not find any excessive polyps here, you might not need to enlarge it excessively. However, in presence of fungal disease inside the sphenoid, one might need to enlarge it even more. Now we use a straight two-cut instruments to palpate the level of bone different between sphenoid and the ethmoid cavity, and we need to break septations. So we use a straight fine true cut, and we start removing the septation between the sphenoid and the posterior ethmoid cells. Each time, the advantage of this technique is that we can palpate the skull base before taking a punch or a bite of the bone. And we strongly recommend that these septations between the ethmoids be removed cleanly using good quality straight or angled through cutting forceps, and not by fracturing them, because often they are attached to the skull base. This is a Heberhold cranial through cut, which is basically a reverse true cut, and this is being used to palpate and remove the bony septations in the ethmoidal cavity, flush with the skull base. Once again, this is very important in clearing all the entire ethmoid cavity, and most importantly, in thorough irrigation of the ethmoidal cavity with saline and steroids to prevent future recurrence, and easy in-office endoscopic examination of the ethmoidal cavity. Imagine leaving septations here would obviously lead to hidden recesses and possibilities of of disease recurrence. Also, not removing enough ethmoidal septations often leads to neo-osteogenesis because of scarring and leads to complications should these patients be requiring repeated surgeries. So one cannot overemphasize the importance of removing ethmoidal septations cleanly for better inspection, better disease clearance, and overall reducing the chances of recurrence in polyp disease, whether it is allergic fungal sinusitis or simple polyp disease. Now, as we keep clearing these septations, we can start seeing the trajectory of the skull base as it slopes from anteriorly, which is superior, to posteriorly, where it is much lower. Once again, since we are operating with an endoscope which is two-dimensional, it is very important to preserve anatomy and understand a three-dimensional part of it, which often gets overlooked. Here we use a straight hedgehog punch to remove some portion of the anterior wall of the agar nasi, just lateral to the axilla of middle turbinate, while being cautious as not to fracture the axilla of the middle turbinate, because that could lead to the turbinate becoming unstable and thus causing its lateralization into the middle meatus, causing again surgical failure. So some bit of removal of anterior wall of agar nasi is very important because it lets us inspect the frontal recess with a 0-degree endoscope quite comfortably. Otherwise, we would have to resort to the angled endoscopes very soon. So that is also fine, but it also creates another opportunity for us to examine. Now we are using an angled navigator probe to point at the frontal beak area where it starts and taking our navigator probe posteriorly to locate and guide us inside the frontal sinus. This can normally be encountered behind the agar nasi when you fracture the posterior wall of agar nasi, like such. As you see here, our probe is going inside the frontal sinus. It obviously goes superiorly and laterally inside the frontal sinus. As you see here, behind the agar nasi cell, freely. Now, once we have located our trajectory, we can simply use our forceps to fracture these cells anteriorly, and we have no fear of the skull base anteriorly, because the skull base lies posteriorly to the frontal sinus. And as we clear more and more bone using a frontal sinus curette or a suction curette, we are able to enlarge our entry inside the frontal sinus. That's important for clearing disease as well as for post-operative irrigation. Now one can start seeing the frontal recess much more clearly. Though our straight frontal sinus suction can go inside the frontal recess and the frontal sinus quite freely, but this might just need a little bit more enlargement to prevent any post-operative stenosis. And we see here that we are constantly fracturing the posterior wall of the frontal recess, which are the type 2-3 cells, the Kuhn cells, to increase our access in the frontal sinus. And here we resort to an angled telescope to reorient ourselves in the skull base. You can see here how the frontal recess and the frontal sinus are very clearly visible, and a suction can very freely move inside the frontal sinus and recess, and you can see the orbital movements, the ballotability from outside. And here you see anterior and median to the frontal sinus, you see the interfrontal septal sinus cell, which can be also, they've also been opened, and the suction can quite freely go. You can see a party wall between them that can be maintained because there's not much disease there. So you can see here how the anatomy is there as seen from an angled telescope from below, something we had seen on the CT, that the frontal sinus and the interfrontal septal sinus cell. Our navigator probe here confirms the same, that this is the frontal sinus indeed, which is slightly posteriorly and laterally, and the other recess that you see here, this one, is basically the interfrontal septal sinus cell, which is medial and even more anterior to the frontal sinus. Now this interfrontal septal sinus cell is only opening on the right side, not to the left side. So opening it on one side is good enough, and we get enough exposure. Both sinuses are nicely open. the ethmoid septations are fairly taken down, the maxilla and the sphenoid is open, and for most part, the right-sided sinus surgery is nearly complete. We begin the same procedure on the left side. We can see polypoidal tissue here inside the middle meatus, which has already thinned the middle turbinate considerably, as seen. So we begin with our uncinectomy, the maxillary enterostomy, and some polyp removal from the middle meatus before we proceed to the anterior ethmoidectomy. And this is a polypoidal and very thinned atrophic middle turbinate because of the pressure from polyps. So we are just reducing it slightly in the inferior half while not traumatizing the superior half. We are using a straight or an angled shaver blade to enlarge the enterostomy, just like we did on the right side. Making the uncinate flush with the lateral nasal wall also is very important, particularly in patients when we have to access the frontal sinus. The superior uncinate must be very cleanly and removed flush with the nasal wall. You can see a partially open bulla here, which again will be removed by engaging the curette behind its posterior wall. Frequent irrigation helps keep the surgical field clean. Here we can see we are again pointing at the transitional enterostomy ridge, the vertical enterostomy ridge like this one, and the horizontal enterostomy ridge or the medial orbital floor on this side. We want to retain and consistently use these landmarks, and we want to emphasize the fact that if we do pursue a landmark-oriented surgery and we create that as a process, then the chances of complications or surgical failures is considerably reduced. Here we use the same frontal sinus true cut forceps to back fracture the ethmoidal bulla. And again, it must be done flush superiorly, cleanly, as well as laterally from the lamina papillaceus, so as to not leave any recesses or holes that impede our vision, lead to swelling of the scope and surgical time wastage. So as we reduce the posterior half of this polypoidal atrophic thinned middle turbinate, what we see here is that we have removing now the excess part of the bulla ethmoidalis, trying to make it flush to the lamina papillacea. And behind the bulla ethmoidalis, one can already see the frontal recess superiorly and the basal lamella. Now, as we explained earlier, the basal lamella is ideally fractured medially and inferiorly. But then that is just a statement as how much medial, how much inferior. The approximate landmark would be, again, as we expressed, the transitional enterostomy ridge, which is the portion of the enterostomy ridge that lies between the horizontal and the vertical enterostomy ridge. And that guides us as a very clear and fair entry inside the posterior ethmoids via the basal lamina. And at the same time, the horizontal enterostomy ridge will guide us into the sphenoid os in case we find scarring and the inability to access the superior turbinate. As we grow here, we are going back through the basal lamina, opening the posterior ethmoidal cavity. Now, as we go inferiorly, you can see here again we are following the transitional enterostomy ridge to open the basal lamella inferiorly and accessing the posterior ethmoids. Now, why we do it is to, of course, avoid any inadvertent injury or penetration into the ethmoidal skull base. As soon as we enter the basal lamella into posterior ethmoids, what we see here is the superior turbinate. And the superior turbinate also in surgery as well as CT is a very important landmark is to decide when we egress from the posterior ethmoids into the sphenoid sinus. You can see here the posterior turbinate tail, and we are trying to go medial to the posterior turbinate to open the sphenoid on this side. Again, as the navigator probe points, it's at the same level as the horizontal enterostomy ridge or the medial orbital floor. Once again, a nearly short way of identifying your sphenoid os in any situations, be it primary or revision sinus surgery. Once we have located the sphenoid os, we enlarge it slightly inferiorly and again inferiolaterally, just like the right side, using a bone punch. Sometimes if the sphenoid wall is quite thin, one can even use a shaver blade. But normally these walls are thick and require a punch to conclusively bite the hard bones. Once again, if one needs to enlarge the sphenoid os inferiorly substantially, it's better to elevate the mucosa from the anterior face downwards so as to protect the septal branch of the sphenopalatine artery. Having to see the maxillary sinus walls, the superior maxillary wall, or so-called horizontal and transverse ridge, and the choana are overall huge perspective creators as we are operating inside the posterior parietal cavity and the sphenoid. Once we open the sphenoid, we know what is the lowest level of skull base, and from therein we start the more and more septation of the ethmoidal cavity from posterior to anterior, and that's obviously a safer way because we go from the lowest part of skull base substantially each time higher. So we see here now that the ethmoidal complex has been opened, the sphenoid has been opened, which is in line with the superior maxillary wall, like this. It's slightly, the os is slightly lateral because the oblique intersphenoid septum, and that has to be more in mind. Like in this case, the sphenoid os is located lateral, not along the septum. And now once that has been opened, subsequently more and more ethmoidal septations will need to be opened. And like I explained initially, the best way to do so would be through an array of either straight or angled through-cut forceps. Now, once the loose bone can be removed partially through a black sea, however, one must be careful as to not to emulse the bone too much because the skull base here is quite thin. So here we use the same reverse through cutting Haber-Holt forceps to cut these ethmoidal septations flush with the roof of nasal cavity of the skull base, because this is a sure shot method because we are not using any torsional forces. With sharp, clean bites through sharp and good quality instruments, we are nearly certain of not causing any breach into the intracranial cavity. Also, these leads to much less mucosal trauma as compared to pulling and avulsing using a Blackiston forceps. So once you see that the sphenoid and the ethmoids have been opened, but that's not complete, now we use this through-cut forceps to each time palpate the skull base and to identify how much more bone lies between the skull base and the ethmoidal cells. And we keep biting into these ethmoidal septations. These septations, when removed flush with the lateral nasal wall, the lamina papyracea and the skull base, ensure a complete ethmoidectomy and easy access into the ethmoidal sinuses for not merely disease clearance, but also post-operative examination using office endoscopy. Here we are using a navigation tracking suction to clear all the clots while seeing the ethmoidal skull base very cleanly here. The frontal recess is also visible here, just behind the frontal beak. As you see here, some minor septations are there, but the ethmoidal dissection appears to me quite okay. We will still examine if there are some recesses left that need to be opened even more. So let me use a microdebator to just briefly and minutely trim the excess indundant mucosa, while at the same time ensuring that we do not cause any circumferential scarring inside the frontal recess, because that is sure to cause stenosis in the frontal recess, which is already quite narrow. Here we are using the divider blade inside the posterior ethmoidal cavity. It does appear that there are a few cells still left to be dissected inside the posterior ethmoidal cavity, and we shall shortly dissect them as well. Now, as you see here, how important it is to dissect all the ethmoidal cells and not leave any recesses behind, because they could be the site of not only recurrent polyp formation as well as new bone formation with new osteogenesis, which can be quite vascular and troublesome in the future. As we see here, the frontal recess and the anterior ethmoidectomy is quite good. The fovea is very clearly visible and minimal septations. And this is again a curved navigator probe showing us that this is the anterior wall of the agar nasi on the left side, just immediately lateral and superior to the axilla of the middle turbinate, behind which lies the agar nasi and the frontal recess. And here, as you see, it leads straight towards the frontal sinus. And this is just because the anatomy here is easy. There are not many cells. You don't have any frontal volar cells or any T3, T4 cells that obstruct our way. But when those cells are present, the frontal sinus dissection can become particularly troublesome and more complicated. So here we are using a very simple ball tip probe to increase our access inside the frontal sinus. You can see here the frontal ostium, the posterior table of the frontal sinus being very clear. Again, we are trying not to use any powered instruments inside this area, using either blunt ball tip probe or the frontal sinus curette, but the curette we normally use with the direction anteriorly and not posteriorly to just enlarge the entry inside the frontal sinus. This helps us significantly in ensuring that post-operative irrigation can reach the frontal ring cell and the frontal sinus and reduce the polyp formation. To increase this slightly further, we would do the same thing that we did on the right side, which is taking down the anterior wall of the agar nasi slightly using a straight Hajduk-Koffler punch. Once again, one must be careful not to destabilize the middle turbinate while going too medially. So this is just superiorly essentially and slightly laterally, as much as the straight punch allows us to do. So here we now take our forceps. You can see there is still a thick septation in the posterior ethmoidal cavity, which impair our vision and access inside the posterior ethmoidal cavity. This is now being taken down using the straight reverse biting through cutting forceps. Now the advantage of this technique is that one can each time palpate before every subsequent cut. Like you see here that we are palpating and then we are cutting and biting the bone each time under complete knowledge of how deep do we have to go. And we can see how, unlike thought so before, there is considerable amount of bone which can still be removed to complete our ethmoidectomy widely. Now, since we are palpating, we still know that there is more bone that can be removed. And again, we can bite in small increments to increase our access so that our ethmoidal cavity becomes essentially like one cavity with minimal or no septations to occlude our vision. So this is a much better way of doing it rather than using curettes or black seal forceps, because all of these exert force. Curettes can sometimes slip and cause CSF leaks, And black sea forceps are also not to be used because they pull the mucosa, they create bare bone, which heals by granulation tissue and scarring, and they also lead to avulsion of these septations, which have direct attachment to the skull base. Now you can see how deep these septations can be. And each time when we palpate these septations, we have in very clear knowledge of the depth of these septations and hence the height of the skull base, and how deep must our instruments go when we access these. So here we see we're using our navigator probe to point towards the fovea ethmoidalis, the minimal amount of septation left, which is quite safe to be left behind, and this shows us as to how to complete the ethmoidectomy with a clear frontal sinus visible to us in front of us. The maxillary sinus, now we use an angled 70-degree telescope pointing upwards to again have an orientation of the entire ethmoidectomy cavity as seen from below. This is an angled telescope is an acquired sort of a taste, so to say, and hugely helpful in managing these lesions, hugely helpful in managing CSF leaks, and it requires us to become familiar with the vision from there. Like you see here, the moment we open these posterior ethmoidal cavities, we did get out some polyps, even with a suction forceps, and now we can see how the ethmoidectomy cavity looks from below, with the maxillary sinus laterally to the right side, and the skull base from sphenoid to the frontal sinus from posterior to anterior, with almost all septations taken down, with a little polyp here we can see from the this thing. Now one must be seeing how important it is to use the instrument with a 70-degree angle telescope. If you put the shaft of the instrument above the telescope, you cannot see, and the shaft of all the angled instruments must be below the angle telescope to be able to gather clear vision of the working part of the instrument. There's the right side again being examined, right side sphenoid sinus with the sella turcica in picture. Not much polyposis here. So our sphenoid sinus opening seems to be at least adequate on this side. The ethmoidectomy cavity is complete. We can see the frontal recess laterally, and like this, there's now the entry into the frontal sinus, which is clear, completely intact mucosa, and the interfrontal septal sinus cell anteriorly and medially, which goes towards the septum. You can see how clearly one can differentiate these two cells